And while St. Mike's is getting their slides ready, I'll introduce Jennifer. Jennifer has presented here at Journal Club many times, first as a resident, then as a PhD candidate, and now we welcome her to present as one of our newest division members. And she's going to do the short presentation on an article that generated quite a bit of conversation amongst the division, as well as on Twitter and in the media as well.
Well, thank you, Dr. Liu, and thank you everyone for coming this morning. As Dr. Liu said, this article, I think, has generated a lot of concern and discussion on the part of many clinicians who work in this area, and so I think there's a lot that we can talk about. As Dr. Liu said, I'm a geriatrician now. I work here at St. Mike's, but a large part of my doctoral thesis work was in learning network meta-analysis methods. And so hopefully I can provide you with a few additional insights into this paper today. So I want to first start by drawing your attention to some of the conclusions that the authors made so that we can think about them as I'm going through this paper. So this first box is actually from the abstract. So right at the beginning of the paper, which is what a lot of people read. You know, they might not read the whole paper, but they'll read the abstract. And so I think this is really important. They say, this network meta-analysis demonstrated that haloperidol plus lorazepam might be the best treatment and Rameltian the best preventive medicine for delirium. None of the pharmacological interventions for treatment or prophylaxis increased the all-cause mortality. They also go on to say that the use of a combination of haloperidol plus lorazepam and Rameltian is suggested for the treatment and prevention of delirium. And actually, in their discussion, they go on to say, and I quote, "Our findings also provide rationales to potentially revise specific treatments and prevention in the treatment guidelines." So the authors make some very strong statements based on their results. And so I think it is important that we try and decide how we feel about the credibility and validity of their results. So first of all, I'm going to talk very briefly about comparing meta-analysis with network meta-analysis, and then the assumptions underlying network meta-analysis, because that's what I'm going to base my critical appraisal on today. So if we look here at the figure on this slide, if we look at panel A, this is a direct treatment comparison. So if we pretend that treatment number 1 is placebo and treatment number 2 is, say, haloperidol, then and we say that, okay, there's maybe been 10 randomized trials that have compared these two studies for a given treatment effect. And in a traditional meta-analysis, we would use statistical methods to pool them together and derive a treatment effect across those 10 studies. However, you can see that it's often the case that there are multiple treatments targeting multiple different outcomes for a given condition. And so in that case, it might be helpful to actually understand the relative treatment effects among the many different treatments that have been used, as well as the relative ranking. So that's where network meta-analysis can be helpful. And so if we look at panel B here, now not only do you have placebo compared to haloperidol, but let's say that treatment number 3 is quetiapine. So now you also have trials directly comparing haloperidol to quetiapine for a given outcome. What we don't have is a direct comparison of placebo to quetiapine. However, using network meta-analysis methods, we can derive what's called an indirect effect estimate to help us understand their relative treatment effects. What you're seeing in panel C is what's called a closed network loop. So now we also, we're going to pretend that there's also a study that directly compares placebo to quetiapine. So therefore, each treatment comparison in this closed network loop is going to be informed by not only direct evidence from the trials that have directly compared those two treatments, but also indirect evidence derived from that closed network loop. These are the 4 major assumptions that underlie any network meta-analysis. The first is homogeneity, which many people are likely familiar with because it's a concept that we also talk about in meta-analysis. So what that means is if we go back to the example of the 10 studies that are comparing placebo to haloperidol, what we need to make clear and to try and quantify with a statistical method is, how similar or different are those 10 studies? what's the age distribution across those studies, what's the sex distribution, what are the different settings that the studies were done, and what were the methods that were used. Because all these things can lead to differences between studies. The next is network connectivity. So that just means, are all the treatments that we're interested in connected to the larger network? And I'll show you examples of that later on. Transitivity builds on the concept of homogeneity. So, in a network, we don't just have the treatment comparison of placebo to haloperidol, we also have the treatment comparison of haloperidol to quetiapine. And so what we need to properly assess is how similar are the studies in the treatment comparison comparing haloperidol to placebo to those studies comparing haloperidol to quetiapine. And we need to look and see, how are they similar, how are they different, and present that in a way that readers can judge for themselves. Consistency is a statistical measure of transitivity. The problem can be that sometimes it's impossible or very difficult to present or to derive an estimate of inconsistency in the network meta-analysis model. And so that's where transitivity becomes even more important. So I won't speak at length about the study methods here, but I'm going to talk about them a little bit and then more as we go through the results and critical appraisal of the study. So to be included in the systematic review for this study, they included randomized trials that were published up until May 17th, 2018. They included only adults. They were interested in any pharmacological interventions that would be used for the treatment or prevention of delirium, although they excluded anesthetic protocols in the peri-op setting. Comparators could be any placebo or control group or other pharmacological intervention that would be used for the treatment or prevention of delirium. Their co-primary outcomes of interest were treatment response in patients with delirium or incidence of delirium in patients at risk of delirium. A secondary outcome was all-cause mortality. And so this led, and they used frequentist random effects network meta-analysis models. And so we'll be talking about the estimates that they derived are odds ratios with 95% confidence intervals and treatment rankings. They used the Cochrane risk of bias tool to assess the risk of bias of studies. And they used different approaches, which I'll talk about later, to assess the global and local inconsistency in the networks. And so this led to the inclusion of 58 randomized control trials in the systematic review. So on this slide, I show you the odds ratios and confidence intervals in a table and in a forest plot for the effect of these interventions on treating delirium. And so what the authors found is that both haloperidol and haloperidol plus lorazepam were more efficacious than placebo or control group at treating delirium. However, one thing that I'd like to point out, and again, this is common to either meta-analysis or network meta-analysis, is that you need to think about who were the people in the studies from which we're deriving these effect estimates. And so many of you will recall, because we praised this article in Journal Club a few years ago, that this haloperidol plus lorazepam treatment effect is based on a single study where the authors compared haloperidol plus lorazepam to haloperidol in a population of patients with advanced cancer who are receiving palliative care. And so we know in palliative care, the goals of care are different, right? It's about quality of life, not quantity of life. And so, not only is this effect estimate derived largely from a single study, but it's based on a study for which the treatment setting and the patients are likely quite different from those other studies that were done in either a perioperative setting or in a general medical ward or intensive care unit setting. So this is a table from the appendix where the authors present their ranking statistics for the different treatments. So they used what's called a surface under the cumulative ranking curve value, or SUCRA value. And so a score of 100 implies that that treatment is certain to be the best, and a score of 0 implies that that treatment is certain to be the worst. So what the authors show you is that haloperidol plus lorazepam has a SUCRA value of 89.7%, but what they don't give us, and what I think is actually quite necessary in this context, is the uncertainty associated with that sucra value, because ranking statistics can be misleading. And one of the reasons that I'm a little bit concerned is that, sorry, I'm going to go back one slide. If we come back to the previous slide, what you can see is that the confidence intervals are very wide associated with these effect estimates. And so when you see this large uncertainty associated with the effect estimates, that can also lead to large uncertainty associated with your ranking statistics. And so it's quite possible, though I don't know, this is pure conjecture, that you could say, you know, the treatment of haloperidol plus lorazepam, yes, it has a sucra value of 89.7, but it's quite possible that the 95% confidence interval stretches from 0 to 100. And so we need to see the distribution of the rankings and measure of uncertainty to really know what this means. And this is a what's called a league table. It's a way of presenting effect estimates derived from a network meta-analysis, because of course there's often many treatment comparisons. And so this is the all-cause mortality associated with delirium treatment in patients who have delirium. And so as the authors concluded, you can see that there's no increased odds of death associated with any of these treatments. However, I think what's also important to note is that, one, they haven't told us the number of deaths across these studies. So it was only, this outcome is only reported in 10 of the studies, and there are 10 treatments, and we see, and we don't know the number of events. So it's quite possible that this outcome could be quite sparse, or that we're sort of underpowered, if you will, to detect a difference from treatments here. And one of the reasons I'm concerned about that is, again, we have very large confidence intervals. And so, you know, while the authors concluded that, okay, there's no increased risk of death, I might have framed it a different way to say, due to the large uncertainty associated with these effect estimates, we can't rule out the possibility that there is a harm from these treatments resulting in death. So this slide illustrates the odds ratios and 95% confidence intervals associated with sort of preventing delirium. So here the authors found out that bromeltian, olanzapine, risperidone, as well as dexmedetomidine hydrochloride were associated with a lower odds of delirium than placebo or control. And they found that midazolam hydrochloride was associated with an increased odds of delirium compared to placebo or control. However, again, one thing that I'd like to point out, and this is again similar to a meta-analysis. You know, in the beginning, when I showed you the conclusions of the authors, they stated, you know, bromeltian might be the best treatment for preventing delirium. However, as we'll recall, again, because we appraised this article in Journal Club, you know, in the last few years, was that this estimate comparing bromeltian to placebo is based on one study for which we did have methodological concerns. I'll remind you that there's only 67 patients that were included in that study, and they had initially assessed 1,126. So a lot of people were excluded. Furthermore, the randomization and allocation concealment in that study was not optimal. For example, they used white envelopes to conceal allocation. Furthermore, the placebo tablets did not match the bromeltian tablets. And while they tried to say that the trial assessors were blinded, they in fact were able to get collateral information from the nursing staff who were administering the medications and would have seen what the medications looked like. So there were some problems with that study. Yeah, and so of course, you know, again, like meta-analysis, the strength of your findings can either be helped or hindered by the quality of the primary studies in your network meta-analysis model. So now on to critical appraisal. So these are the network diagrams that the authors presented in their main paper. And one of the problems is that, you know, I'd like to be able to explain what these network diagrams mean, except that the authors didn't actually tell us how they made them, which is important because there's different ways to do this. I'm going to make some assumptions in what I'm about to tell you. I could be wrong, but this is sort of my best guess as to what they're presenting to us. Is that, as you can see, there are a number of different nodes or circles that are associated with each of the treatments. And so I think the size of the node indicates in how many studies that treatment has been studied, and that the lines connecting each of the nodes represent the fact that there's been a direct treatment comparison between those two treatments, and the thickness indicates how many times that treatment comparison has been made. So I'll first draw your attention to the B figure here for delirium prevention. A couple of things to note. One, there seems to be quite a lot of sparsity, particularly in this part of the network, which, as you'll recall, risperidone, olanzapine, and ramelteon were said to be more efficacious than placebo or control. But it looks like they're only compared in one study each, and there's no closed network loops here, which means we can't assess for inconsistency. And in fact, I think there's only 2 closed loops in this entire network, which again makes it very technically challenging to assess inconsistency. In the delirium treatment network here, we do have some more closed loops, which is good, but there is still some sparsity over in this upper part of the network. And in fact, the authors don't present us with a way to assess transitivity, which is really unfortunate, because as I said, given the fact that we can anticipate some difficulty in assessing consistency, this is really important. Usually you should present either a figure or a table that would allow readers to look across the treatment comparisons in a network meta-analysis model and decide how similar or different are these studies. And this is even also important because of this information. So in the appendix, the authors present a table where they present the between study standard deviations, which is the statistical way of presenting the heterogeneity of the network model. And where the arrows are, I put those there because I just want to point out that that's very large, heterogeneity. And it's not discussed in the paper, and it's not further explained in the appendix beyond what you see here. And it's a little bit harder to interpret because, in a meta-analysis, for example, many people are familiar with like a nice bird statistic. If it's like 75%, well, that's a lot of heterogeneity. This is a little bit less intuitive and kind of context specific. You actually need to compare it with like an informative prior distribution to know, how big is this given this context. But this is large. And so this is sort of what I think many people are concerned about. And when you see this, you need to do subgroup sensitivity analyses, meta-regression to try and explain it. The authors do comment on having looked at the impact of age, use of rescue medications, and a subgroup of studies that used IV medications. But I think there are other characteristics that we're also interested in, particularly the impact of study setting, which they didn't look at. And another thing is that because there's so much heterogeneity here, there are theoretical reasons why it makes it even more difficult to detect inconsistency in your networks. And so that's what this slide shows. This is a table, again, from the appendix that's illustrating their assessment of inconsistency. So they assessed inconsistency 3 ways, though I'll remind you, in the delirium prevention, which is the bottom part of that table there were only 2 closed network loops, which makes it, there's lots of other treatments for which we can't do an inconsistency assessment. But if we want to look here at the top, where we're looking at the treatment of delirium, not its prevention, you can see that there is consistency detected. And they report sort of an overall estimate for what's called the loop approach there. Usually when people do the loop approach, they also report what are called inconsistency factors, because that approach, what it's most useful for is actually that you can find what loop in the network has inconsistency and the size of that inconsistency to then try and sort it out, which they don't present. But they did another model called a side splitting approach, where I was able to see that there seems to be inconsistency in a loop of evidence that involved olanzapine, placebo, and haloperidol, which, if you'll recall, the authors found that haloperidol was more efficacious than placebo for treating delirium. But then they don't necessarily totally sort out this inconsistency. It's mentioned very briefly in the study that they tried to remove one study that had a large effect estimate, and that fixed things. Or they still found that haloperidol plus lorazepam was the most efficacious treatment in the network. And so in conclusion, I put up again the author's conclusions at the top so that you can be reminded of them. So they said that haloperidol plus lorazepam might be the best treatment, and rameltian the best preventive medicine for delirium, and that none of the pharmacological interventions for treatment or prophylaxis increase the all-cause mortality. However, I would say that my interpretation of the results and conclusions is hampered by a number of things, most notably the significant or the large between study differences that are noted, but not very well described in the paper or explored by the study authors. Quite sparse networks of evidence, with few now closed loops. We did, however, still find inconsistent evidence in the networks. The authors don't present us with a transitivity assessment. There's very large uncertainty associated with some of the effect estimates, which I think is particularly problematic for this last point, where the authors try to say that none of the pharmacological interventions are associated with harm from death. I don't think you can say that. And they don't give us very much information about the ranking statistics to make them actually helpful in ranking interventions. So that is everything. I know we're kind of at time, but if people have, people are welcome to ask me questions, or you can email them to me. I do have a Twitter handle. I was going to say I'm not really on Twitter. Now I seem to actually go on a little bit more. I will say I follow Camilla, and I also follow Larry the cat. Actually, that's what's really getting me onto Twitter, is that I'm curious to see what Larry the cat is up to. So now I can take questions.
Thanks, Jen, for a very clear explanation of network meta-analysis.